Hi guys, and welcome to our module on the lungs, the pleural, and the pleural cavity. The lungs are paired organs of the lower respiratory tract. This includes other organs like the bronchioles, the bronchus, the trachea, which we talked about in a separate module. The lung is found in the thoracic cavity. It occupies a large chunk of the thoracic cavity bilaterally, and it is connected to the trachea via the bronchus. It's covered by pleural membrane, which we'll talk about, and is surrounded by the pleural cavity, which we'll also talk about in this model. Being a paired organ, we have two lungs in the thoracic cavity, one on the right side of the thorax, the other on the left side of the thorax. It's important to note that though there are differences between the right and the left lung, both work concurrently to ensure that we are breathing well. And if there's a problem with one lung, that could automatically affect the quality of air that we breathe as a result. And some of the presentations, a patient that has a problem with just one of the lungs could come down with would be things like difficulty in breathing, um, fast breathing, what we call tachypnea, or slow breathing, what we call bradypnea. So, what are the functions of the lung? The first function of the lung is in the process of gaseous exchange. That is made possible by the presence of a blood-air barrier that allows for the exchange of oxygen for carbon dioxide. Besides this, the lung also contains some important immune cells known as alveolar macrophages that helps in the phagocytosis of dust particles and microorganisms that got there through inhalation. So let's talk about the structure of the lungs. Each lung tends to be described as a cone or pyramidal shaped structure, and there are four important structures or four important features of each of the lungs that you should know about. The first would be the surface. So the lungs, whether right or left, have surfaces to them. Then we talk about the borders of the lungs. The borders are the edges where each of the surfaces tend to meet. Then, very importantly, the lobes of the lungs, each of the different lungs, right and left, have different numbers of lobes. And then finally, we have the hilum of the lung, which is the um, uh, entry point of structures into or out of the lungs. So let's start with the surfaces of the lungs. We have four major surfaces of the lungs. This usually tend to depict the structures surrounding that particular lung. And in terms of the surfaces, we have the cervical surface. Cervical surface of the lung is surface of the lung that is in direct contact with the neck. That's the apical part of the lungs here. Cervical means neck, and that's the reason why we call it cervical surface. Then we have the diaphragmatic surface. The diaphragmatic surface is a surface that tends to sit above the diaphragm. This entire area here is the diaphragmatic surface of the lung, also called base. Then we have the mediastinal surface. The mediastinal surface is the part that faces the mediastinum. So the part of the lungs of facing one another or facing each other are separated by that midline space we know as mediastinum is called the mediastinal surface. And this is the mediastinal surface of the lungs here. Then finally, we have the costovertebral surface. The costovertebral surface is the part that is surrounded by ribs and vertebrae, and that's the area not necessarily shown here, but that's the area that I'm outlining in this particular image. So just to quickly recap the different surfaces of the lungs and their description, the cervical surface, like I said, is also called the apex, and it tends to extend into the superior mediastinum. It usually forms the boundaries or lateral boundaries of the superior mediastinum. Then the diaphragmatic surface, like I said, forms the base. It tends to sit directly on top of the diaphragm. And then the costovertebral surface, the largest of the surfaces, tends to be bounded or surrounded by the thoracic cage, the ribs, and the vertebrae. And then finally, the mediastinal surface, the part that is found lateral to the mediastinum and tends to face one another. We have three borders of the lungs. The borders of the lungs are just the points where each of the different surfaces tend to meet. So we have what we call the anterior border or the mediastinal border. That is typically where the mediastinal surface meets the costovertebral surface anteriorly. You have the vertebral border or the posterior border. That is where the mediastinal surface meets the costovertebral surface posteriorly. So this is the posterior border here, and this is the anterior border here. Then we have the inferior border. The inferior border or diaphragmatic border is the border where the mediastinal surface and costal surface meets the diaphragmatic surface. So this is the diaphragmatic bone inferior border in the image here. So quickly outlining a different important aspect of the borders. Like I said, the mediastinal border separates the costovertebral surface from the mediastinal surface posteriorly. It's a thin and sharp border. The vertebral border, on the other hand, is it's also called the anterior border, separates the costovertebral surface from the mediastinal surface anteriorly. And it's a broad and round border. And finally, the diaphragmatic border or the inferior border separates the costovertebral and mediastinal surfaces from the diaphragmatic surface. Usually tends to be a sharp border. Let's talk about the lobes of the lung. Each lung tends to be divided into lobes. This division is made possible by spaces that exist between the lobes known as fissures. So we have one of the lung, maybe the right lung, having multiple fissures and dividing that lung into different lobes. Same thing with the left lung. So just to distinguish between the right and the left lung in terms of the lobes, the right lung has a total of three lobes, and these three lobes is made possible by the presence of two fissures or lines of division. So the three lobes includes the upper lobe, the middle lobe, and the lower lobe. And then the two lines of division, what we call the two fissures that forms the three lobes of the right lung, includes the horizontal lobe fissure and the oblique fissure. Then on the left side, we have two lobes on the left side. Those two lobes are made possible by just a single line of division known as the oblique fissure. So the two lobes includes the upper lobe and the lower lobe. And this is going to mirror the amount of lobes we have in the lung is going to mirror the amount of lobar bronchus we have. Because remember, we talked about lobar bronchus in a separate model, and we said the lobar or secondary bronchus are on the right and the left side are different in terms of number. So on the right side, we have three secondary lobar bronchus. Those three secondary or lobar bronchus fit perfectly into the three lobes of the lungs. And then on the left side, we have two secondary lobar bronchus. These two secondary lobar bronchi in the left lung fit perfectly into the two lobes of the left lung. So each lobe of the lungs is further divided into segments. So if we have three lobes in the fact that we have three lobes on the right lung, three lobes on the right lung are further divided into a total of 10 segments. And then the two lobes on the left lung is further also divided into 8 segments. And each of those segments are supplied by what we call a tertiary or segmental bronchus. Remember that when talking about a tertiary bronchus in a separate model, we mentioned the fact that on the right side, the right um, tertiary bronchi are 10 in number, and then the left tertiary bronchi are 8 in number. So they marry well with the 10 segments of the lungs on the right lung on the right side, and then the 8 segments of the lungs on the left side. And the combination of the segment of the lungs and the segment of the um of the bronchus gives rise to what we call the bronchopulmonary segment. So bronchopulmonary segment is just a combination of the segmental bronchus of the lungs and the segmental bronchus and the segment of the lungs. So let's talk about the bronchopulmonary segment. Bronchopulmonary segment is the anatomical, functional, and surgical unit of a lung. What this means is that if we are to break down the lung into its most divisible form, that divisible form is going to be a single bronchopulmonary segment. Functionally, each bronchopulmonary segment can function entirely by themselves without affecting or being affected by segments that are intervening or surrounding them. So functionally, the bronchopulmonary segments by a unit or a single unit of bronchopulmonary segment can function by itself. And then surgically, bronchopulmonary segments can be resected if need be. Let's say there's a lung tumor, a lung cancer, we can, rather than taking out the entire lung, just resect the bronchopulmonary segments that have been affected. It's the largest subdivision of a lobe. It is pyramidal in shape, and very importantly, in terms of how it is placed, the apex of the bronchopulmonary segment tends to face the hilum of the lungs. It's very important to remember. And then the base of the bronchopulmonary segment tends to face the costovertebral or pleural surface of the lung. Each bronchopulmonary segment contains, as said before, a segmental bronchus and a pulmonary artery. And each of them tend to be supplied independently by the segmental bronchus and supplied independently by the tertiary branch of the bronchopulmonary of the pulmonary artery. What they don't get independent supply of or exclusive supply of usually tends to be the pulmonary vein. The pulmonary veins are usually located within the connective tissue septa that separates the bronchopulmonary segment. So each of the bronchopulmonary segments are separated by a connective tissue septa, and along that connective tissue septa, we have the pulmonary veins that supply at least more than one bronchopulmonary segment. So they don't get exclusive or independent supply of venous drainage. Rather, they do get exclusive or independent supply of the segmental bronchus and the tertiary branch of the pulmonary artery. So just to illustrate that point I mentioned, the bronchopulmonary segment is drained by what we call intersegmental parts of the pulmonary veins. These veins tend to lie along the connective tissue that separates different segments, and so they lie adjacent to the segments that they are supplying. So one vein can drain two or more different segments. The last aspect is the fact that the segments are surgically resectable. I mentioned this when talking about the fact that the bronchopulmonary segment is the structural or anatomical, functional, and surgical unit of the lung. The last aspect of the lungs to remember would be the hilum of the lungs. The hilum of the lungs is the part of the lungs that tends to be located at the mediastinal surface. It serves as a point of entry and exit for structures that are either entering into or leaving the lungs. Some of the structures are largely neurovascular structures. We'll talk about that. It's important to note that there are differences between the hilum of the right lungs and the hilum of the left lung. We'll talk about what that entails there. But before we go there, pleura, which we'll talk about very soon, tends to cover the entirety of the lungs. But once it gets to the hilum, it tends to reflect below the hilum and tends to form a very unique sheet as it reflects below the hilum. We'll talk about that when we see pictures of the hilum of the lungs. So this is a picture of the hilum of the lungs, and just to quickly talk about the different aspects of the hilum and what is found there. So remember I said the hilum serves as a port of entry and exit for structures um, into or out of the lungs, and because of this, the collection of all the structures that are either entering or exiting the lungs are known as the roots of the lungs. So these structures include things like the bronchus, the pulmonary artery, superior pulmonary vein, the inferior pulmonary vein, the bronchial artery, bronchial vein, bronchial nerves, and bronchial lymph nodes. And these are images are depicted. You would also pay attention and notice, if you pay attention, you notice that a number of these roots of the lungs are wrapped around by uh, pleural membrane, and usually pleural membrane tends to form like a sleeve that descends or elongates downwards. That's what I was talking about. And that sleeve is known as the pulmonary ligament. So when they talk about structures found in the hilum of the lungs, you talk about the root of the lungs and the pulmonary ligament. The root of the lungs will include all the structures I mentioned. And then the pulmonary ligament is that parietal pleura that tends to just um, reflect on becoming the visceral pleura and then forming that pulmonary ligament I mentioned. So there's some important differences between the right and the left lung in terms of the hilum. Let's start with the pulmonary artery. The pulmonary artery on the right side tends to be found inferior to the lobar bronchus. On the left side, the pulmonary artery is found superior to the lobar bronchus. And usually, that what that means is that on the right side of the lungs, the superior lobar bronchus is the most superior structure on the hilum, and then on the left side, the pulmonary artery is the most superior structure on the hilum. This is the reason why on the right side we tend to call the superior lobar bronchus the epiarterial bronchus. Besides that, the superior pulmonary vein on the right side tends to lie just caudal to the artery, just below the artery. And then on the left side, the superior pulmonary vein tends to lie anterior to the bronchus. And this is one important difference. Then finally, on the right side, the inferior pulmonary bronchus or the inferior pulmonary vein lies inferior to the bronchus, and this is also similar to the left side. In the left side, we have the inferior pulmonary vein also inferior to the bronchus. So this is not necessarily a difference, but this is more of a similarity in both to the right and the left side. On the hilum, the inferior pulmonary vein is found inferior to the bronchus. The differences tend to be in the superior pulmonary vein and in the pulmonary artery. This is a picture depicting what I described. You look at this is the right lung. On the right side of on the right lung, the hilum of the right lung, we have that pulmonary artery shown here. You can see how the pulmonary artery is found as the most superior structure above the bronchus. You can see it above the lobar bronchus. And you also notice that the superior pulmonary vein in this image is found anterior to the bronchus to the right side, whereas the inferior pulmonary vein is the most inferior structure. On the left side, the difference is on the arrangement of between the artery and the bronchus. So if you notice on the left side, we have the bronchus being the most superior structure, particularly this superior lobar bronchus being the most superior structure, and as a result, we call it the epiarterial bronchus, followed by the and that is followed by the pulmonary artery. All right. Then we have the inferior lobar bronchus here, and then the um the superior pulmonary vein tends to be the most anterior structure shown here. It's the most anterior structure here, but it's inferior to the it's the most anterior structure. However, it is inferior to the pulmonary artery. And then finally, the inferior pulmonary vein is the most inferior structure there. And that is a similarity we find on the right side and the left side. The vascular supply to the lungs comes in two fashions, comes from the pulmonary vein and the bronchial vein. It's better to know that the pulmonary vein is there to carry deoxygenated blood and oxygenated blood to and from the lungs. So we have the pulmonary artery carrying deoxygenated blood to the lungs for oxygenation. And then we have the pulmonary vein carrying oxygenated blood from the lungs to the heart for it to be distributed across the body. The bronchial vessels, whereas, is the vessel that tends to give nourishment to the lungs. So it's the vessel carrying oxygenated blood to the lungs and draining the oxygenated blood from the lungs. And it's the major vessel involved in supplying the lungs, just like every other um, organ in the body has vessels supplying it. And then in terms of nerve supply, the lungs is supplied by plexus of sympathetic and parasympathetic nerve known as the pulmonary plexus. The lymphatic drainage of the lungs comes in different fashion. Usually, we have a number of nodes that are found around the mediastinum, around the thorax, and within the lungs that helps in draining lymph from it. Some of these nodes includes the intrapulmonary nodes found within the lungs, the bronchopulmonary nodes found at the junction between the lungs and the bronchus, the hilar bronchial nodes. This is extremely important nodes, especially when talking about a common pathology like tuberculosis. Usually, these nodes tends to be enlarged in case of tuberculosis. We have the paratracheal nodes and then the bronchomediastinal nodes. So, talking about the embryology of the lungs, it's important to revisit the embryology of the trachea. Remember that the trachea begins from the foregut at the fourth week. At the fourth week, we have the foregut eventually giving rise to an outpouching we call the respiratory diverticulum. Then, with time, the respiratory diverticulum separates from the foregut to form a ventral trachea and a dorsal esophagus. The trachea automatically, the structure contained that is derived from the trachea, which is the respiratory diverticulum, would eventually begin to um, um, grow or mature downwards distally, and it gives rise to what we call the lung body. From this lung body is where the lungs would be formed from. So the development of the lung bud into the lung tends to mature in a proximal distal direction. And as a result, we see that the proximal pulmonary tissues will be more advanced in period or of development than the distal pulmonary tissue. There are four stages of lung development. So as the lung bud is developing proximal to distal, there are different stages of each of the different tissues of the lungs, and each of those stages tend to progress from one step or from one uh, point to the other along the entire length of the intrauterine life. So these stages includes the pseudoglandular stage, all right, then the canalicular stage, the terminal sac stage, and then finally the alveolar stage. Start with the pseudoglandular stage. This occurs around the fifth to 7th week. So this is just from beginning, the starting point of the lung bud formation. At this stage, the lung reserve moves an exocrine gland, and that's the reason why we call it pseudoglandular stage. It is lined by simple columnar epithelium, and the respiration is virtually impossible at this stage. Usually, children born at this stage are usually premature and they can't survive because the lungs are not developed in any way or form that could assist or that could attain respiration. So all the parts of the lungs are usually formed at this point, except for structures for gaseous exchange, which is the most important in the first place. And we have a presence of modest capillary network as well during this particular stage. Second stage is the canalicular stage. The canalicular stage occurs from the 16th week down to the 25th week. The epithelium of the lungs in this stage is made up of simple cuboidal epithelium. Respiration is possible. However, premature infants before 20th week tend to rarely survive. So usually, once you start getting above 20 weeks, survival is possible. However, this depends on geographical location, right? So survival of infants usually at 28 weeks is possible in Nigeria, but in other countries like developed world like the US or UK, that survival usually tends to be less, like 24th week, the 22nd week, because of the advances of pediatric care over there. Usually at this stage, we have the presence of prominent capillary networks in the lungs. Signs that respiratory bronchioles are already starting to form at this stage, and then the alveolar duct are also forming. Usually, respiratory bronchioles begins around the 16th week at the beginning of the stage, and then we start to see alveolar duct at the end around the 25th week of the canalicular stage. Third stage is the terminal sac stage. Terminal sac stage is a stage from the 24th week down till birth. At this stage, we start to see the terminal sac board of the alveolar duct, and from there, because of the terminal sac is present, and we see that respiration can occur from here, and respiration can be the child can survive as a result. Usually, this stage, the epithelium is lined by simple squamous epithelium that allows for gaseous exchange. And there are two types of cells found in the simple squamous epithelium. We have the type 1 pneumocyte and the type 2 pneumocyte. And at this stage, we have rapid proliferation of capillary networks at this particular stage, and that allows for exchange of gas between the terminal sac and the capillaries. So capillary network comes in contact with the terminal sac and forms that blood-air barrier that it spoke about. And from there, gaseous exchange can occur. Premature children born from the 24th to 26th week may survive, depending on the geographical location. That's virtually based on the level of intensive care that the child receives. But usually, before anything before the 24th week or 26th week, the child may undergo or suffer what we call a respiratory distress syndrome because of a very important substance called surfactant produced in the lungs. So usually that type 2 pneumocyte I mentioned produces surfactants. Once type 2 pneumocyte is formed and surfactants start to be produced by the type 2 pneumocyte, usually are beyond 24th to 26th week, the child can survive. But if a child is born prematurely before 24th or 26th week and doesn't produce surfactants, that can lead to respiratory distress syndrome, because surfactants is there to the maintain the airway. If surfactant is lacking, that can lead to collapse of of the lungs, collapse of the alveoli, and as a result, respiratory distress syndrome occurs from there. The last stage of lung development is the alveolar stage. This occurs usually starts overlapping the terminal sac stage, starts at the second week and extend all the way till birth, all the way to the 8th year of childhood. During this period, we have the terminal sacs being partitioned by a secondary receptor to form the adult alveolar. And then the amount of terminal sacs and alveolar also increase from birth till the 8th year of life. Usually around birth, we have about 20 to 70 million alveoli present at birth. At the 8th year of life, we have about 300 to 400 million alveoli present within the lungs. So let's talk about the histology of the lungs. In this case, we'll focus only on the aspect of the lungs that histologically relevant. That would include the respiratory bronchioles, the terminal bronchioles, respiratory bronchioles, and the alveoli, because those are the areas of the lungs that we didn't talk about. So starting with the bronchioles, bronchioles are the extension of the segmental bronchus, as described in the previous model. They contain three major structures forming the wall, the mucosa being the most inner structure that lines the lumen, followed by the submucosa and then muscle, the muscularis layer. The mucosa is lined by simple ciliated columnar epithelium, just like we see in the bronchi above it. Let's talk about the histology of the terminal bronchioles. Terminal bronchioles, just like the segmental bronchioles, is also made up of three layers of tissue that forms its wall. This includes the mucosa, submucosal, and the muscularis layer. The mucosa of the terminal bronchioles tend to be distinct because of the combination of two types of tissues that we find there. First is the simple sedated cuboidal epithelium. Then second is what we call Clara cells. So what are Clara cells? Clara cells are typically cells that tend to replace the goblet cells that we find elsewhere in the respiratory tree. They are non-ciliated cells that tend to secrete protein, glycoprotein, and lipid-rich secretions into the airway. And these secretions tend to act as surfactants. So they are unique because they are similar to the surfactants we see in the alveoli, and they help in maintaining the the tension within the lungs and helping to keep open the lumen of the bronchioles and the lumen of the alveoli. So let's move on to the respiratory bronchioles. This is made up of a single wall, which is formed by mucosa. The mucosa of the respiratory bronchioles is lined also by simple ciliated columnar, simple ciliated cuboidal epithelium rather, and Cara cells. One unique difference between the respiratory bronchioles and the terminal bronchioles is the ability of the respiratory bronchioles to undergo gaseous exchange, as compared to the terminal bronchioles that doesn't undergo gaseous exchange. So, and the reason for that is because we just have a single layer of wall on the respiratory bronchioles that would help in forming that blood air barrier, and that layer is the mucosa itself. So the last aspect of the histology of the lungs is the alveoli. Alveoli are sac-like structures that are made up only of epithelial cells. The epithelium of the alveoli is simple squamous in nature. It's a very thin lying epithelium that varies in diameter from about 0.2 to about 2.5 nanometers. That thinness of the simple squamous epithelium of the alveoli makes it or allows for easy, rapid transport of gases, carbon dioxide and oxygen specifically, from the air in the lumen of the alveoli into the capillaries and then vice versa. So, I said before, the alveoli is a sac-like tissue surrounded by capillaries, and the combination of contact of the capillaries with the alveoli gives rise to the blood-air barrier. These capillaries are derived from the pulmonary artery, and the gaseous exchange tends to occur between the alveoli and the capillaries as a result. Within the alveoli, we have two major types of cells. This includes the type 1 pneumocytes and the type 2 pneumocytes. Each of them have different functions, and I'll talk about that in the next slide. The difference between type 1 and type 2 pneumocytes are numerous. These are differences in terms of the shape, in terms of how much coverage they have in the entire alveoli, in terms of their function. So the type 1 pneumocytes are usually large flattened cells. Type 2 pneumocytes are smaller cells, also flattened in nature. Remember that they both form simple squamous epithelium across the entire alveoli. In terms of surface area, the type 1 pneumocyte makes about 95% of the total alveolar surface area. The type 2 pneumocyte makes about 5% of the total alveolar surface area. In terms of their total population, this is where the desiccations tend to play a role as compared with the surface area. The type 1 pneumocyte tends to make about 40% of the total number of cells, and then the type 2 pneumocyte makes about 60%. So although the type 2 pneumocytes are more numerous, they cover very short surface area. Um, Whereas for the type 1 pneumocytes, although they are fewer in number, they tend to cover a large surface area of the alveoli, and that's one important distinction to make. So in terms of surface area, type 1 pneumocyte takes a large chunk. In terms of the population of cells, type 2 pneumocyte takes the large chunk. And functionally, type 1 pneumocytes are the cells that are involved particularly in gaseous exchange. Whereas for type 2 pneumocytes, functionally they're involved in the secretion of surfactants that helps in maintaining that tension within the alveoli and allows for each of the alveolar sac to be patent. If there's a problem with surfactant, as mentioned before, it leads to collapse of the lung, and as a result, that can affect the respiration of the child or respiration of the individual, leading to respiratory distress syndrome. Second aspect of this particular model focuses on the pleura. The pleura is a thin double layer of serous membrane that surrounds the entire thoracic wall and lungs. We have two major forms of pleura, depending on where they are covering. This includes the parietal pleura and the visceral pleura. Parietal pleura tends to cover the thoracic wall. That's the area that is shown here. The visceral pleura tends to cover the lungs. That's the aspect shown here. Between the two pleura, we have a space there, and that space is known as the pleural space or pleural cavity. So starting with the parietal pleura, like I said, parietal pleura tends to line the thoracic wall, as shown here. So it lines the entire thoracic cage from the inside and also extends all the way to the mediastinum, lining the entire mediastinum from the inside. What are the parts of the parietal pleura? So depending on what particular aspect of the entire thoracic cage it is lining, the parietal pleura has four major parts. That's the cervical band, that's the part of the parietal pleura extending to the neck, and covering the thoracic cage and the lungs around the neck. Then we have the mediastinal part of the parietal pleura that covers it along the mediastinum. Then the costal parietal pleura that covers or lines the entire ribs. Then diaphragmatic parietal pleura that lines the diaphragm. Usually, when we talk about parietal pleura, it's important to note what we call the pleural reflections. Pleural reflections are junctions between different parts of the pleura. So, where the costal and diaphragmatic pleura or the costal and mediastinal pleura tends to meet is what we call reflections. They're reflecting off one another. And there are two major types of reflections. There's the coastal mediastinal reflection and the coastal diaphragmatic reflection, as the name implies. So, coastal mediastinal reflection is the junction between the costal pleura and the mediastinal pleura. So that is depicted by this line. So this is the coastal mediastinal reflection here. The coastal diaphragmatic reflection is the reflection or the junction between the costal pleura and the diaphragmatic pleura here. That's depicted by the line here. Both of these reflections tend to communicate with one another. You can see how the coastal mediastinal reflection meets the coastal diaphragmatic reflection here. So let's talk quickly about each of those reflections, starting with the coastal mediastinal reflection. On the right side, the coastal mediastinal reflection has a very unique part compared to the left side. On the right side, the coastal mediastinal reflection tends to descend medially from the sternoclavicular joint. So from the sternoclavicular joint at this point, we have the reflection descending down. It descends at the level of the seventh costal to the level of the seventh costal cartilage. You can see it runs all the way down and ends at the level of the seventh costal cartilage. And from that point, it becomes the coastal diaphragmatic reflection. So from this point, becomes the coastal diaphragmatic reflection as shown here. On the left side, we tend to see a different parts of the coastal mediastinal reflection. So the coastal mediastinal reflection on the left side also begins from the the sternoclavicular joints at this point. It descends all the way down, first of all, to the fourth costal cartilage. So once it gets to the fourth costal cartilage as shown here, it tends to run obliquely as a result. So it descends obliquely rather than vertically towards the sixth costal cartilage. So at the sixth costal cartilage, it now eventually becomes the coastal diaphragmatic reflection. The reason why this occurs, the reason why on the right side we have the coastal mediastinal reflection just running vertically from the sternoclavicular joint all the way down to the seventh costal cartilage, whereas on the left side the coastal mediastinal reflection runs first from that sternoclavicular joint to the fourth costal cartilage and then runs obliquely to the sixth costal cartilage is because of the bare area of the pericardium. The pericardium or the heart tends to occupy largely the left aspect of the thorax, and that the presence of the heart on that side tends to separate or tends to deflect the costal mediastinal reflection and pushes it obliquely from the fourth costal cartilage down to the sixth costal cartilage. Let's talk about the coastal diaphragmatic reflection. The coastal diaphragmatic reflection tends to be the continuation of the coastal mediastinal reflection. Like I said, it is the reflection or junction between the costal pleura and the diaphragmatic pleura. It continues or begins rather from the seventh costal cartilage on the right and on the right side, and on the left side from the sixth costal cartilage. From the on the right side on the seventh costal cartilage, it begins to descend towards the 12th rib. So that descent towards 12th rib is important to note what tends to happen across that along that particular descent. Usually at the eighth costal chondral junction or the eighth costal cartilage, we say that the coastal diaphragmatic reflection is found in the mid clavicular line. So if I'm to trace that the costal diaphragmatic reflection, it starts from the seventh costal cartilage. Once it goes to the eighth costal cartilage, we say it is at the mid clavicular line. Meaning, if we draw a line across the entire clavicle, that line will cut across the costal diaphragmatic reflection, particularly on the eighth costal cartilage. As it keeps descending down obliquely, once it gets to the 10th costal cartilage, we say that it is found at the mid axillary line. So at the 10th rib, rather, or the 10th rib, not costal cartilage, 10th rib, the costal diaphragmatic reflection is said to be at the mid axillary line. And then finally, once we get to the 12th rib, as it reflects to the 12th rib, at the 12th rib, we say that um, costal, the costal diaphragmatic reflection is found at the scapular line. So each of these are very important points. They are points that they can ask you in your MCQ question or English questions. The particular position or site of the costal diaphragmatic reflection as it passes through the seventh costal cartilage, to the eighth costal cartilage, 10th, and then the 12th rib. So the blood supplied to the patellar peritoneum comes from a number of different arteries. These include the internal thoracic arteries and veins, posterior intercostal arteries and veins, superior intercostal artery and vein, and the superior phrenic arteries and vein. The nerve supply comes largely from intercostal nerve and phrenic nerve. Let's talk quickly about the visceral pleura. The visceral pleura tends to line the outer surface of the lungs. In terms of its blood supply and nerve supply, it's supplied by the bronchial artery and by the pulmonary plexus, which is a combination of sympathetic and parasympathetic nerves. The last aspect of this model is on the subject of the pleural cavity. Pleural cavity is a potential space that lies between the parietal and visceral pleura of the lungs. As shown in the image here, you can see that the parietal pleura of the lungs tends to line the thoracic cage, and then the visceral pleura of the lungs tend to line the lungs, the outer surface of the lungs. Between them, there's a potential space found there. That space is known as the pleural cavity or the pleural space. The pleural space tends to contain small amount of fluid, and what is there for is for the function of movement, allows for the movement and expansion of the lungs and prevents wear and tear between the lungs and the thoracic cage as the lung expands during inspiration. So as said, the pleural cavity and the fluid within it serves a number of functions, one of which is to lubricate the pleura, so it lubricates both the parietal pleura on the thoracic cage and the visceral pleura on the lungs. It helps in decreasing friction as well. It decreases friction when the lungs expand. The pleura of the lungs, that's the visceral pleura, will meet and rub on the parietal pleura of the thoracic cage, and that fluid there is to limit the friction there and limit wear and tear. Finally, the space is there to produce surface tension that helps in drawing the two pleura together during respiration. Just as we have reflections in pleural membrane, we also have recesses in the pleural spaces. So a pleural cavity or pleural space tends to expand at specific points to form what we call recesses. And there are two major recesses found within the pleural cavity. This includes the costal mediastinal recess and the costal diaphragmatic recess. The very first recess is the costal mediastinal recess. This is an expansion of the pleural cavity at the point where the costal and mediastinal pleura tend to meet, and that's depicted in the image here. Then we have the costal diaphragmatic recess. The costal diaphragmatic recess serves as an expansion point of the pleural cavity at the junction where the costal and diaphragmatic pleura tend to meet. So usually, we see the costal diaphragmatic recess at this particular point. You can see this blue area here. There's a very huge space between the lungs and the thoracic cage, and that space is formed between the visceral pleura of the lungs and the parietal pleura of the thoracic cage and the diaphragm. It allows for the lungs to be pulled in and expanded during inspiration because of that extra space there. So let's conclude this model by talking about some important clinical significances. So first will be respiratory distress syndrome. I mentioned this before. It is a particular condition that occurs whenever there is reduction or deficiency or surfactant in the lungs, and this allows for or this leads to collapse of the lungs because the alveoli will not be able to maintain its patency. Usually seen in children that tend to be born earlier than expected, so in premature in infants tend to come down with respiratory distress syndrome. Tuberculosis is also very important. I mentioned the fact that hilar lymph nodes found within the lungs are important sites where tuberculous reactions could occur. Pneumonia is also very important. It's just an infection of the lungs. Pulmonary genesis, when the lung doesn't develop. Atelectasis, which means collapse of the lungs. Emphysema is a process whereby the lungs becomes extremely, or the alveoli of the lungs become extremely large and don't maintain their elasticity. And as a result, expiration becomes a problem because you need the elasticity of the alveoli to be maintained. And we have the pneumothorax. Pneumothorax is when air is present within the pleural cavity. Then we have pleural effusion. Pleural effusion is where fluid is present within the pleural cavity. Excess fluid. Usually, we have a small amount of fluid that maintains that lubrication and friction. But when there is excess amount of fluid in the pleural cavity, we call that pleural effusion. Then we have pericardiocentesis. This is just the process of taking a fluid tap in the pericardium. Usually, this is done at that bare area of the heart that I mentioned when talking about the pleural reflection. Then thoracocentesis as well. It's just similar to pericardiocentesis, but we're doing it usually at that costodiaphragmatic recess. And then finally, we have the mesothelioma. Mesothelioma is simply tumor of the pleural membrane. So yes, they're just images depicting for us the different aspects of the clinical significance. As I mentioned, this is a child that was born premature. A child that's born premature will likely have a collapsed alveoli or respiratory due to respiratory distress syndrome as a result of deficiency of surfactant being produced. This is the picture showing us pulmonary tuberculosis. Pulmonary tuberculosis tends to be due to an infection of Mycobacterium tuberculosis. It could affect the alveoli of the lungs and specifically tends to present as granulomas, and usually lymph nodes are affected, especially lymph nodes that are going to be draining lymph from the lungs, like the higher lymph nodes as mentioned before. This is a picture of a pneumonia. Pneumonia is when there's infection of the alveoli. Usually, what happens is that air sac or air-filled space of the alveoli tends to be congested by fluid and bacteria, shown here. This is a picture of emphysema. Emphysema is when we have the alveolar sac being damaged to the point in which it becomes excessively dilated and is reduces the force of expiration that we tend to have as a result, and is usually one of the causes of obstructive lung disease that we see in adults as well as in children. And that concludes our module on the lungs, the pleura, and the pleural cavity.